Hello folks, today we'll be discussing about secondary glaucoma. We will be completing this class in 2 sessions. Hi, I'm Dr. Rashmi Malhotra and I'm Assistant Professor in DMC Ludhiana. It's a group of disorders in which the rise of intraocular pressure is associated with some primary ocular or systemic disease. So it can be classified based on mechanism of intraocular pressure rise. It can either be secondary open angle glaucoma or it can be secondary angle closure glaucoma. Or it can also be classified depending upon positive primary disease, that is can be phacogenic, that is lens induced glaucoma. It can be pigmentary glaucoma, neovascular glaucoma, inflammatory glaucoma, that is post-uveitic, traumatic glaucoma, steroid induced glaucoma, pseudo exfoliation glaucoma, or glaucoma associated with intraocular tumors like malignant melanoma or retinoblastoma. Then there can be secondary open angle glaucomas, which can also be based on location, like pretrabecular. That is, trabeculum is open, but there is a membrane that is covering the trabecular meshwork, like in case of epithelial, endothelial, fibrous, fibrovascular, or inflammatory. Or there can be trabecular, like some particle is obstructing the trabecular meshwork. Trabeculum is open, but there is a particle that is obstructing, like in case of RBCs, or WBCs in case of inflammation, neoplastic cells, pigments, pseudo-exfoliation material, viscous material like silicone oil, helon, lens particle, vitreous or fibrin. Or it can be due to trauma or toxicity to trabecular meshwork, like in case of edema, tears, toxins or lasers. Or it can be post-trabecular, that is, there is increased episcleral venous pressure because of which pressure is rising, like in case of superior vena cava obstruction, thyroid eye disease, AV fistulas, or Sturge-Weber syndrome. Then there can be secondary angle closure glaucoma with pupillary block. Pupillary block occurs secondary to some pathological change in the eye, like in case of swollen lenses, that is phacomorphic glaucoma. The lens is swollen, which leads to iris lens apposition and hence pupillary block, or mobile lens syndrome. For example, in case of ectopia lenses or microspherophakia, that is lens is in interior chamber or it is coming in apposition of iris frequently leading to pupillary block, or extreme miosis, for example in anticholinesterases, like which leads to pupillary constriction, hence it increases the lens iris apposition, or ciliary contraction, that is forward lens movement leads to pupillary block. And there can be secondary angle closure glaucoma without pupillary block, that is anterior pulling mechanism. For example, neovascular glaucoma, there is formation of ectropion UV or peripheral anterior synechiae due to pull of the fibrovascular membrane over the iris, or iridocorneal endothelial syndrome, that is there is a pull by the tonofilaments of the epithelialized endothelium and Descemet's membrane of the cornea over the iris, or posterior polymorphous dystrophy, in which there is dysplastic corneal endothelium that produces basement membrane like material which covers the angle. So let's discuss some form of secondary glaucomas. Let's start with lens-induced glaucoma. It occurs because of raised intraocular pressure secondary to a disorder of crystalline lens. It can either be secondary angle closure because of phacomorphic or phacotoxic, or it can be secondary open angle like phacolytic, lens particle glaucoma, or phacoanaphylactic glaucoma. Let's start with phacomorphic glaucoma. The causes are intumescent lens, anterior subluxation or dislocation of the lens, or spherophakia, that is phacotopic variant. What is happening here? The swollen lens pushes the iris forwards, which obliterates the angle. Patient generally presents with acute congestive glaucoma here. The treatment is mainly surgical, that is cataract extraction with implantation of IOL. But before proceeding for surgery, we have to control the pressure. It can either be done with IV mannitol or oral acetazolamide along with topical beta blockers. Once the pressure is controlled and inflammation is controlled, we can go ahead and do the surgery. That is the main treatment. Then another form is phacolytic glaucoma. Here, the trabecular meshwork is clogged by the lens proteins and macrophages that phagocytose the lens proteins and inflammatory debris. Here again, first we will lower the pressure, followed by the extraction of cataractous lens with PCIOL implantation. In all kind of lens-related glaucomas, main treatment is cataract extraction with IOL implantation. But before that, we have to control the pressure. Then we have lens particle glaucoma. Here, the trabecular meshwork is again blocked by the lens particle itself, which is floating in the aqueous chamber. The main management is again removal of the lens particle from the anterior chamber. But before that, we have to control the pressures by medical therapy. Then we have phacoanaphylactic glaucoma, which is a fulminating acute inflammatory reaction due to antigen antibody reaction. Basically, it is a granulomatous form of uveitis, which precedes disruption of the lens capsule and leakage of proteins from the lens. Basically, there is an antigen antibody reaction occurring against the proteins of the lens, which leads to increase in intraocular pressure. So here again, the management first is to control the pressures by medical therapy. Along with this, we also have to treat the iridocyclitis with steroids and cycloplegics. And finally, we have to do irrigation and aspiration of lens matter from the anterior chamber. Now let's discuss another entity which is also known as pigmentary glaucoma or pigment dispersion syndrome. It occurs because of clogging up of trabecular meshwork by the iris pigment particles. These pigments are released by mechanical rubbing of the posterior pigment layer of the iris with zonular fibrils. Typically, these patients are young myopic males. Features are generally similar to primary open-angle glaucoma, and there is deposition of pigment granules in anterior segment. This is a typical feature which is noted in pigmentary glaucomas, which is also known as reverse pupillary block. What is happening here is that intraocular pressure is higher in the anterior chamber as compared to posterior chamber, which forces the iris to bow backwards. This leads to a unidirectional pressure difference which prevents fluid from flowing back into the posterior chamber. Plus, there is constant friction and rubbing of the bowed iris with the anterior lens zonules, which releases the pigments, further leading to rise in pressure. So this vicious circle does not stop. Hence leads to reverse pupillary block and increased intraocular pressure. The classical triad of pigmentary glaucoma is Krukenberg spindle, which is a pigment deposition on the endothelium in a vertical spindle-shaped pattern, mid-peripheral iris transillumination defects, and dense trabecular meshwork pigmentation. Then there is another very important form of glaucoma, which is known as neovascular glaucoma. It is an intractable glaucoma that occurs due to neovascularization of iris and angle of the anterior chamber. It is mainly due to retinal ischemia. Retinal ischemia is the main causative factor. Like in case of diabetic retinopathy, CRVO, sickle cell retinopathy, Eales disease, and chronic intraocular inflammation. So all these causes lead to chronic retinal ischemia, which leads to release of angiogenic factors like VEGF, which leads to neovascularization of iris, that is rubioiridis, and neovascularization of the angle. Eventually what happens is there is formation of fibrovascular membranes, which eventually contract and zip the iris against the cornea. So large peripheral anterior synechiae are formed, blocking the trabecular meshwork, hence leading to intractable neovascular glaucoma. These are the stages of neovascular glaucoma. First, there is pre-glaucomatous stage, which is a stage of rubiosis iridis, that is, iris neovascularization occurs. Then there is open angle glaucoma stage, where the formation of pre-trabecular neovascular membrane occurs. Eventually, there is secondary angle closure glaucoma, in which there is contraction of this neovascular membrane, which gives a zipper angle closure, leading to goniosynechiae and hence glaucoma. So basically, neovascular glaucoma is a form of mixed type of glaucoma in which first there was the angles were open, later they closed. This is an intractable form of glaucoma which requires treatment from both retina and glaucoma side. First, there has to be pan-retinal photocoagulation to decrease the ischemia. Intravitreal anti-VEGF injections are required, followed by mydriatrics and corticosteroids to control the inflammation, which is followed by filtration surgeries like trabeculectomy with mitomycin C. But generally in these situations, filtration surgeries fail. Hence, patients require glaucoma drainage devices and eventually, if the patient presents late, sometimes requires cyclodestructive procedures like cyclocryotherapy. So this was our session 1 for secondary glaucoma. We'll have another session on secondary glaucomas. Thank you.